Okay, next I'm going to be talking a little bit about obstetric analgesia and anesthesia. So, the visceral pain from cervical dilation results in the T10 to L1 spinal segments. And the descent of the head, that pain is going to be down with S2 through S4, and that's with the pudendal nerve. So if you want to decrease the pain from the baby coming out, you've got to block the pudendal nerve, S2 through S4. In the absence of medical contraindication, maternal request is a sufficient medical indication for pain relief during labor. So if the mother wants it, the mother gets it. That's kind of the rule with that. There are some absolute contraindications to regional anesthesia, like epidural, spinal, or combination, and these are the following. Refractory maternal hypotension. So if the mother has really, really low blood pressure, if you're going to give her a spinal or some sort of anesthesia that might lower it, you might want to reconsider that. A maternal coagulopathy. So if the mother has some sort of clotting disorder, or maybe she doesn't clot or clots too much, one of those two things, you may want to not give that because it could cause problems. Maternal use of once daily dose of a low molecular weight heparin within 12 hours. So if they've taken heparin, they might bleed too easily, and that could be fatal, especially since baby giving birth is a very bloody thing. Skin infection over the site of the needle placement. I don't want to cause infections there. Or increased ICP caused by a mass or lesion. Intracranial pressure. Okay, so now talking about some of the medical complications of pregnancy. There are quite a few. So one of the complications of pregnancy here is going to be something called hyperemesis gravidarum. This is an odd word, hyperemesis gravidarum. Basically, it means that the mother vomits a lot during her pregnancy. It can cause acute starvation, ketonuria, weight loss. It's a pretty bad thing. It's more common the first time the mother's pregnant, or if there's multiple babies in there, or with molar pregnancies. You usually see elevated beta-HCG and elevated estradiol have been implicated in its pathology. So they think maybe beta-HCG and estradiol have something to do with this. So when you're going to do the history and physical exam, you need to distinguish the difference between morning sickness from hyperemesis gravidarum. So, with the morning sickness is going to be some acid reflux, some gastroenteritis, maybe hyperthyroidism, neurological conditions. There might be some of these things, and you need to kind of distinguish those things from morning sickness or from hyperemesis gravidarum. You got to figure out what's what. So you got to take a good history and physical. Good diagnosis for some of these conditions would be to check the beta-HCG level and ultrasound to rule out a molar pregnancy, because remember, the molar pregnancy does cause really elevated beta-HCG. Evaluate for ketonemia, ketonuria, hyponatremia, and hypokalemic states, hypochloremic and hyperchloremic metabolic alkalosis. Measure liver enzymes, serum bilirubin, serum amylase, and lipase. Usually, with morning sickness, if the morning sickness continues after the first trimester, that's usually where you want to start thinking hyperemesis gravidarum. And the first thing you want to rule out in the case of hyperemesis gravidarum is you're worried about a molar pregnancy, so you got to do that ultrasound. If you see the snowstorm appearance on ultrasound, then you might be thinking, this might be molar pregnancy. Okay, so what do you do as far as treatment? So some of the treatment options here is to administer vitamin B6. You can also get something called doxylamine, and it's an antihistamine. You can give promethazine or dimenhydrinate. And if it's really, really, really bad, you might think about getting metoclopramide, ondansetron, prochlorperazine or promethazine. And if they're dehydrated, which is sometimes the cause, if someone's vomiting a whole bunch, of course they can't get their fluids down, you might want to consider giving IV fluids or maybe even IV nutritional supplementation along with diamond hydrogenate IV. So diabetes in pregnancy is divided into two categories. There's gestational diabetes and there's pregestational diabetes. Gestational is the onset is during pregnancy, and pregestational is the onset prior to pregnancy. Okay, gestational diabetes mellitus is where the person has a carbohydrate intolerance of variable severity that is first diagnosed during pregnancy. Occurs 3 to 5% of all pregnancies, and usually it's later in pregnancy. The mother, so there is something in the mother that tries to prevent sugar from going into cells so that the sugar can stay in the bloodstream so that it can get to the baby and to milk and things like that. It's basically something that makes the cells a bit resistant to insulin. And if the mother has too much of that, that can cause, they think that may be associated with this gestational diabetes. So for the diagnosis, you need to conduct a 1 hour 50-gram glucose challenge test. So 1 hour 50-gram glucose challenge test. I don't know why they call it a challenge. And then what you need to do is you need to test the venous, I guess just say, check the plasma glucose 1 hour later. Okay? And when do you do this? This is going to be at 24 to 28 weeks. And how do you know? So you get the results back from the plasma glucose test. What's normal? Well, any value that is greater than 140, or really greater than 139, anything higher than 139 equals abnormal. Okay, which means they have most likely gestational diabetes. Okay, so, but you need to do another test. One test isn't enough. So the next thing you're going to do is you're going to confirm it. How are you going to confirm it? You're going to confirm it with something called a 3-hour 100-gram glucose challenge test. And for this one, pretty descriptive as to what happens. The person comes in fasting, and they're given 95 milligrams per deciliter. Fasting, sorry. Their fasting should be 95 milligrams per deciliter. And then within 1 hour, should above 180 milligrams per deciliter. And then at 2 hours, it can be any one of these numbers. 2 hours, 155 milligrams per deciliter. And 3 hours, greater than 140 milligrams per deciliter. So if any of these cases, if their fasting is greater than 95, if after 1 hour of taking 100 grams, they have a 180 milligrams per deciliter. After 2 hours, 155, 3 hours, 140. Any of those results are that case, then what do we say? We say that the person has gestational diabetes. This confirmed our concerns that they do indeed have gestational diabetes. So what about treatment? What do we do for treatment for this? Treatment is pretty straightforward. With the mother, we're going to start on, so I'm going to put a gestational diabetes treatment. It's going to be something called the ADA diet. Okay? Consists of regular exercise, strict glucose monitoring 4 times a day. Okay? So they want to keep tight maternal glucose control. And why? Because if the mother does not control her glucose, then all that glucose is going to go to the baby. And if it goes to the baby, then the baby is going to get something called macrosomia, and it may even have some other kinds of deformities. It's not good for the baby as it's developing to be bathed in sugar blood. Okay, not a healthy thing for the baby. So we want to try to avoid that. So The fasting glucose, we want to keep it, below 90. For the anyway, so we want to add insulin if we have to the mother, and that helps get some of that sugar into the cells that are kind of insulin resistant. Says give intrapartum insulin and dextrose to maintain tight control during delivery. So during the delivery, you may need to give some dextrose, you may need to give some insulin, and kind of really keep it tight during that time. For the fetus, what do you need for the fetus? That's stuff you do for the mother. What about for the fetus? So for the fetus, you're going to obtain, I guess you're just going to do ultrasound and NSTs, non-stress tests, to assess the growth, okay? Also, you might need to, around 39 to 40 weeks, you may need to, it says, it may be necessary to induce labor at 39 to 40 weeks if insulin or an oral hypoglycemic agent is necessary for glucose control. So that means that if the mother has been having to take insulin or something like that, some other drug that's going to control her glucose, then the baby might be too big, okay? And if the baby might be too big, then you might have complications, so you want to deliver the baby around that time, so that if the baby does have macrosomia, it's not going to cause too many problems. Won't have too much time to get too big. Some of the complications, it says 50% of patients develop glucose intolerance and a type of type 2 diabetes mellitus. They eventually will develop that. So that's a bummer. So if they did have gestational diabetes, it's very likely that later on they will develop diabetes later on in life, type 2 diabetes. So what about pre-gestational diabetes? So let's say, we were just talking about gestational diabetes, but what about pre-gestational diabetes? Okay, well in the case of pre-gestational diabetes, there's treatment for the mother and there's treatment for the fetus. So let's talk about the mother first. So treatment for the mother with pre-gestational diabetes, you need to look for renal, ophthalmologic, neurotube, and cardiac evaluation to assess for end organ damage. See, this sugar causes something called a non-enzymatic glycosylation. So essentially this sugar molecule is going to bind to proteins, and then it's going to warp the proteins. So the proteins are all messed up, okay? And it messes up things in your eyes, it messes up things in your blood vessels, in your heart, and all over the place. Kidneys, it's a bad deal. So we want to test those to see if they're okay. And then we're going to really strictly control it with diet, exercise, insulin therapy, and frequent self-monitoring to minimize fetal defects. And they have here, if it's pre-gestational, we want to do a fasting morning. So it means they come in that morning, they fast, and they want to see less than 90 milligrams per deciliter. And the 2-hour postprandial, less than 120 milligrams per deciliter. Okay, what about the fetus? So the baby, okay, so 18 to 20 weeks, we want to do an ultrasound to see the baby's growth. We want to look for the fetal age and growth. We want to check for cardiac problems, anomalies, and also polyhydramnios. Polyhydramnios basically means that there's too much fluid in the baby. Okay, so 32 to 34 weeks, we're thinking, really watching this baby really closely. So NST, CST, BPP, these are just like the non-stress tests, or the CST was the contraction stress test. So we give some oxytocin or stimulate the nipples. And then the BPP was those 5 things we talked about earlier. I can review it really quickly for a second. It was the here it is. Multiple, no. Sorry, one moment. BPP, here it is. So fetal tone, breathing, movement, amniotic fluid volume, and non-stress test. And they give those a rating of 0 to 2 for all of them, and then if it's a score of 8 to 10, they don't worry about it. So it's like 5 things. Score of 2 is good. Any one of them is low. If it gets below like a 6, you really start worrying pretty seriously. Really below 7, you're kind of concerned. So, all right. So you perform all those tests, make sure if it's been controlled. You need to explain that it's a pretty big concern. It's not being controlled, and after the delivery of the baby, it says maintain normal glycemia, 80 to 100 during labor. Sorry, this is during labor, with an IV insulin drip and hourly glucose measurement. So the whole time, if you're delivering on a diabetic mother, you need to make sure that her blood sugar is somewhere between 80 to 100. You have insulin ready to drip in there, and you have sugar ready to drip in there. Consider early delivery in the setting of poor maternal glucose control, preeclampsia, macrosomia, or evidence of fetal lung maturity. Cesarean delivery should be considered in the setting of an estimated fetal weight, so EFW, estimated fetal weight greater than 4,500 grams. Encourage breastfeeding with an appropriate. Now, what is? Sorry, I'm kind of curious. So I'm going to pull up here. Convert grams to pounds. So let's see what that says. That is not kilograms, grams. So that's going to be like about close to 10 pounds. So if it's like a 10-pound baby, probably want to do a cesarean section. Pretty close to 10 pounds. Okay, so delivery, postpartum, let's see, where was I? One thing too, so if the baby does have macrosomia, it comes out, one thing you got to realize is this baby has been pumping out insulin like there's no tomorrow to handle all this sugar. So when the baby comes out, there's a real concern, a real risk of the baby becoming hypoglycemic, which means that it's taken all of its sugar and it's put it in its cells, and now it doesn't have enough sugar in its blood. And so when the baby first comes out, you may really need to give the baby some sugar pretty quickly when it first comes out. All right, I'm going to go ahead and end this video, and we'll start up